Hello guys, welcome to Fast Code 21 Medical Coding YouTube channel. The purpose of this channel is to help the people who are in need of medical coding reliable resources. If you are already subscribed to our channel, help your friends to subscribe. If you are visiting for the first time, then click on subscribe button to receive future updates in medical coding. Basically, the channel is helpful for freshers, experienced coders, aspirants of AAPC and AHIMA certifications. If you have any doubts or other topics or concerns, please mention in the comment section. Please click on like button to encourage and motivate us. Please watch until the end to gain in-depth knowledge about ICD-10-CM, CPT, EPIC coding systems. As these Q&A sessions are very useful in live coding, medical coding interviews, CPC and CCC certification process. CCS, sorry. If you go to any interviews, keep familiar with the code books like ICD-10-CM, CPT, HICPICS. As our Q&A sessions will assist you in the process of interviews or in the certification exams, but not an alternative to original interview process and certification exams. So these sessions will assist you in the process of exams or certifications, but you need to rely on your coding material and code books. So today we are going to learn about Certified Risk Adjustment Coder Preparation Course Part 2, and Part 1 is already included in the Fast Coder 21 Medical Coding YouTube channel as SEC/Risk Adjustment Coder Q&A Part 1. As you know, nowadays most of the people are joining in SCC coding process. The reason for this is, so SCC utilizes only ICD-10-CM coding system. So along the way, most of the people are looking for Certified Risk Adjustment certification process. So here we are going to start to help the people who are planning to write Certified Risk Adjustment CRC medical certification exam. So please note, Part 1 named as HCC CRC Common Interview Questions and Answers is already published in our Fast Coder 21 YouTube channel. Please check that video also. So now without delay, we can start our learning process. Here we have first question. Patient presents with pulmonary fibrosis following radiation and chronic respiratory failure. Assign the appropriate codes. So basically it is testing us. How do you code pulmonary fibrosis following radiation and chronic respiratory failure? As these are two conditions, we need to code two codes. Before that, we need to check what are the meaning of pulmonary fibrosis and chronic respiratory failure. So basically, pulmonary fibrosis is a serious lifelong lung disease. It causes lung scarring. Scarring means tissue scar and thicken over time, making it harder to breathe. Symptoms may come on quickly or take years to develop. There is no cure for pulmonary fibrosis. So we need to code as a HCC condition as it exists for life. Medications may slow down scarring and help preserve lung function. Oxygen therapy and staying active may relieve symptoms. So as you know, the conditions which are not curable we will consider as chronic conditions, as pulmonary fibrosis is also one example for chronic condition. So we need to code this. And also we need to check what is the meaning of chronic respiratory failure. So chronic respiratory failure is a condition that results in the inability to effectively exchange carbon dioxide and oxygen. So what are the synonyms of pulmonary fibrosis? The approximate synonyms are fibrosis of lung following radiation, fibrosis of lung. So basically these synonyms means whenever we find this wording also we need to code pulmonary fibrosis code only. So what are the synonyms for chronic respiratory failure? Chronic respiratory failure and respiratory failure chronic. Now we need to check how to find these two conditions in the ICD-10 CM book. So for pulmonary fibrosis, you need to check first fibrosis, then lung, then following radiation. So we need to check fibrosis, lung, following radiation. It can lead to J70.1. And also we need to look for respiratory failure like failure, respiratory, chronic. So it will lead to J9610, and we need to verify these two codes in the tabular list. So basically there is no rationale for this question. It is direct question only. Just we need to check the keywords and find it in the ICD-10 index, and as well as we need to check it in the tabular list. Second question, which of the following statement is not true regarding inpatient? Sorry guys. So in first question our answer is J70.1 and J9610. So J70.1 is for pulmonary fibrosis, J9610 for chronic respiratory failures. As there is no guidelines regarding these two codes, we need to code them directly using the index as well as tabular. So I have mentioned here answer is A. So our next question is, which of the following statement is not true regarding inpatient? A. Inpatient must have admission. DOS means date of service, and discharge DOS, discharge date of service. B. HMP note may be coded separately. C. Consultation note must be coded as physician. D. ED note we can code separately. So for second question our answer is C. So consultation note must be coded as physician is not correct. So as our question is asking which is not true, so consultation note must be coded as physician is not true. So the rationale for this C answer is, if the consultation date of service is other than the through dates, they like admission or discharge, then it can be coded as hospital outpatient services. Through means it is not in the middle of admission DOS and discharge DOS. So when it is consultation service is not in between the admission DOS and discharge DOS, we need to consider it as hospital outpatient service. So when it is within the through days, then it can be clubbed and coded as inpatient stay. So when it is consultation note is in between admission DOS and discharge DOS, we need to code it as inpatient stay. Consultation inpatient setting, physician and qualified non-physician practitioner permitted. So we can, consultation is permitted in inpatient setting. It is very simple. So we need to check the admission DOS and discharge DOS. If the consultation date is in between admission DOS and discharge DOS, we can consider that consultation as inpatient stay. If the consultation date is not in between the admission DOS, discharge DOS, we can consider it as hospital outpatient service. So here the answer is consultation note must be coded as physician. So it is not like that. So that's why this answer is incorrect. Why means consultation note we need to base the code based on the admission DOS and discharge DOS. If it is between admission and discharge DOSs, we can code it as inpatient stay. If it is consultation note date is outside of these dates, admission DOS and discharge date DOS, we can code it as hospital outpatient services. So here our answer is C. Next question, third question. Patient's presence with follow-up of prostate cancer and excised 4 years ago. Today came to withdraw PSA. What is the action? So here it is a follow-up of prostate cancer which is excised 4 years ago. That means there is no prostate cancer currently. So but patient came in for like a surveillance of prostate cancer, whether it still exists or not. For that they are going to do PSA means prostate specific antigen test. Using that test they can find whether patient has prostate cancer or not. So here the answer is Z8546B. So here already patient has prostate excised, and so because of that reason we need to code Z85.46 as history of prostate cancer. If the patient has current cancer, we need to code C61. So the meaning of here is, here patient has PSA test, but we don't know the result. So that's why we have coded Z85.646 based on the document. We have not coded based on the PSA test result. If we find the PSA test results are positive, we need to code it as C61, as PSA positive means patient has prostate cancer. If it is PSA negative means we need to code Z85.46. That means there is no prostate cancer in patient. So our answer here is B. So here, fourth question, what is the ultimate goal of CMS RADV? So I hope all you guys know about RADV. So it is like, as you guys know here, CMS RADV means Center for Medicare and Medicaid Services. RADV means Risk Adjustment Data Validation. So here our question is, fourth question, what is the ultimate goal of CMS RADV? So we need to select among these four to find the answer. First one is A, to improve the clinical documentation. B, to audit or evaluate risk scores of patients. C, to identify cases of suspected improper payment. D, to treat all diagnoses with the same financial weight. Here our answer is B, to audit or evaluate risk scores of patients. So what is the rationale for that? Basically the ultimate goal is to evaluate CMS proposed changes in risk adjustment strategy closely and the collection of all relevant information from the patient medical records of MA plans. Using this risk adjustment, using current year data, CMS evaluate next year's like burden of the patient, like how much amount we need to utilize for this patient in next year. So our fourth question answer is to audit or evaluate risk scores of patients. So based on these risk score only, patients will get benefits. Fifth question is atherosclerosis of lower extremities with ulceration of right calf and debridement for gangrene. Assign the proper code. We need to check here. So here among these all, our answer is A, I70.261, L97.219. The rationale for that answer is, these are direct questions only, so we need to check in the index to find the correct answer. So in index we need to check first arteriosclerosis, then we need to find extremities, then we need to find leg, then right, then width and gangrene, and intermediate claudication, rest pain and ulcer. So it will lead to I70.261, and we need to check it in the like tabular list. So tabular list we have one guideline. We need to code whether patient has any ulcer or not. So for ulcer we need to code L97.219. So here the answer is I70.261, L97.219. Answer A. So whenever we check the documentation like ulceration, we need to check whether it is pressure ulcer, normal ulcer. Usually pressure ulcers arises due to the continuous sitting or idle position. Here physician has not mentioned any pressure, so we need to code it as normal ulceration. Sixth question, prospective review done. A, daily or weekly basis. B, past 12 months data to be validated. C, bi-monthly. D, past 3 years. Here our answer is A, daily or weekly basis. So the rationale for this answer is, basically a prospective review also termed as pre-billing audit or review, which is done before billing is submitted. So this is done by some medical practices daily, weekly or monthly. So it is the discretion of medical practices how they want to do prospective review. So here our answer is A, daily or weekly basis. Question number 7, bed sore in the sacrum of tailbone. Here too we need to select among these 4 answers: A L89 150, B L98 429, C L89.159, D L98.499. Here our answer is C. So as we have discussed before, it is a pressure ulcer. Why means because of the continuous bedridden condition, these pressure ulcers will arises. So how do you check in the index? We need to check ulcer, pressure, sacral. Usually we can call sacral as tailbone also. So we can get the L89.15 and we need to verify this code in the tabular list. So here in this in our question there is no stage mentioned. So that's why we need to code it as L89.159. So if there is a stage, this 6th character will change. Here there is no change, that's why we need to code L89.159. Basically we have 4 stages here. As in our document, in our question there is no stage mentioned. That's why we will code here it as unstageable pressure ulcer. Unstaged pressure ulcer, sorry. Otherwise you can call it as unspecified pressure ulcer stage. So if you have pressure ulcer stage, this code will change. So whenever you find this bed sores in the sacrum of tailbone or like pressure ulcer, we need to check the stage. Wherever the stage in the document, we can take it as a stage, and based on that stage we have separate code. Question number 8, patients presents with the symptoms of dehydration. In the past, MRI of pancreatic head and pancreatic cancer metastasized to liver. Today diagnosis with dehydration. We need to check how do you code. How do we code this condition? So we need to check among these 3 answers. For this we have ICD-10 CM guideline. We will go there and check. If you check in our guideline, management of dehydration due to the malignancy. So here in this situation, patient has dehydration and the patient has malignancy. So here when the admission or encounter is for management of dehydration due to the malignancy and only the dehydration is being treated, intravenous dehydration, the dehydration is sequenced first followed by the code for the malignancy. So that guideline suits to our question here. Patient has dehydration here due to the pancreatic head and pancreatic cancer, which pancreatic cancer is metastasized to liver. So here our answer is A. Why means E86.0 is for dehydration, C25.0 is for pancreatic cancer, and C88.7 is for metastasized to liver. So here E86.0 dehydration, C25.0 is for pancreatic head cancer, C78.7 is for secondary liver cancer. As primary is here pancreatic cancer, secondary is liver. Metastasized to liver means this is from pancreas it is expanded to liver. So that's why we can code liver cancer is secondary code, pancreatic cancer is primary code. So based on all this discussion, our answer is A here. So dehydration, pancreatic cancer and liver cancer, secondary liver cancer. 9th question, which of the following can be submitted for RADV solely? A. Lab test results, B. Radiology results, C. DME claims, D. Pathology notes. Here our answer is pathology notes, so we can give pathology notes for RADV purpose. So our answer is D here. So our next question, 10th question, patient presents for dressing of tracheostomy. Assign the appropriate code. So here we have 4 options: A Z93.0, B B J95.03, C J95.00, D Z43.0. So here our answer is D. It is direct question. Just we need to go to index, like we need to check attention, then tracheostomy. It will directly lead to our answer Z43.0. So our next 11th question. Which of the following will help you to identify issues during RADV audit? A. High risk score with less medical claims. B. Low risk score with high medical claims. C. High risk score with high medical claims. D. Low risk score with low medical claims. Here our answer is B. So low risk score with high medical claims. So the rationale for that answer is low risk score equates to lower payment. So if the patient has low risk score means it need to give lower payments. So risk adjustment data validation audit identify low risk score with high medical claims. Basically RADV checks for low risk score with high medical claims. So because of that reason our answer is B. Question number 12. Which of the following statement is not true? A. DM with PVD and DM with atherosclerosis of lower extremities E11.51 and E11.59. B. DM with PVD E11.52. C. DM with cardiovascular disease E11.69. D. DM with polyneuropathy E11.42. So among these four we need to check not true. That means which one is among these four, one is incorrect. We need to find that one. So whenever we find this type of codes, we need to check the question properly. If there is not here, not wording here, there may be a chance of correct or wrong answer. So we need to check the question properly. So here our answer is B. DM with PVD. Usually we will code it as E11.51, but here it is mentioned as E11.52. So B is wrong answer. So here we need to find the not true. So DM with PVD is E11.5 is not true. So our answer is B. 11.52 is not correct. 11.51 is correct. So next question 13. Which document will be used for RADV audit? So among these four, our answer is B. HCCs in a hierarchy category can be submitted either of lower risk score or higher risk score. So rationale for that is, so RADV audit use documents with HCCs in a hierarchy category can be submitted either of low risk score or high risk score, which is a RADV principle. Next question 14th one. Patient admitted for infection of catheter in bloodstream due to sepsis. Among these four, our answer is B. Here our answer is B. First we will code A41.9 sepsis and next we will code bloodstream infection T80.211A. So initial encounter. So we need to check sepsis in the index and also we need to check infection of catheter bloodstream in the index. To find this answer there is no guideline pertaining to. So here our answer is B. A41.9 for sepsis, T80.211A for bloodstream infection of the catheter. So next question 15th one. When does Medicare adjustment plan submit the diagnosis to CMS? So usually here our answer is D. Usually MA plan to submit the diagnosis to CMS is first quarter and third quarter of every calendar year. This is also direct code. We need to remember that answer. 16th question. Atonic seizure is characterized by. So here among these four, our answer is A. Loss of muscle tone which results in sudden collapse and fall. So rationale for that answer A is atonic seizures, also known as, you can call it as drop seizures, cause a loss of muscle control which may cause you to suddenly collapse or fall down. Myoclonic seizures. So myo means muscle related to muscle. So here myoclonic seizures means related to muscles. So myoclonic seizures usually appear as sudden brief jerks or twist of the arms or legs. Clonic seizures are associated with repeated or rhythmic jerking muscle movement. These seizures usually affect the neck, face and arms. Facial seizures without loss of consciousness alter emotions or change the way things look, smell, feel, taste or sound. So among these criteria, our answer is A, loss of muscle tone which results in sudden collapse and fall. So next question 17. Which of the following organ is present in abdominopelvic region? A, hypothalamus, B, gallbladder, C, heart, D, lung. So basically this hypothalamus is located in the brain. So heart is located in the chest area or chest cavity. Lung too associated in the chest cavity or chest area. So here gallbladder is the correct answer to denote abdominopelvic region organ. So here our answer is B, gallbladder, which is present in abdominopelvic region. So question number 18. What does missed abortion mean? So here our answer is A, fetus is dead but is not delivered. So what is meant by missed abortion? In a missed abortion, the pregnancy will not progress because although the woman retains embryonic and or placental tissue in her uterus, the embryo either never formed or died of natural causes. So here the fetus is dead but is not delivered. So it will stay inside the uterus. So then we can call it as missed abortion. So here our answer is A. Basically in missed abortion, fetus is dead but it will not expelled outside, it inside the uterus only. Question number 19. The pulmonary arteries carries. So among these four, our answer is B. In all body arteries, only one artery which carries deoxygenated blood is pulmonary artery, which carries deoxygenated blood from right ventricle to lungs, which is the exception for arteries function. Usually arteries carries oxygenated blood, but this pulmonary artery for deoxygenated blood, which is the one exception in the human body to carry deoxygenated blood. So our answer is B. Next question, 28th question. If you are following predictive modeling and the patient has DME order for oxygen supply, a prescription claim for bronchodilator and medical claim for pulse oximetry, what diagnosis will you predict? So which is a very direct question. There is no thinking to do. So here oxygen means usually oxygen supply is related to respiratory condition, and bronchodilators are also related to respiratory conditions, and pulse oximetry is also related to respiratory condition. Here among all four, diabetes DM is related to endocrine system, CHF is related to cardiovascular, COPD is related to respiratory, HTN related to cardiovascular. So here our answer is C, based on DME order for oxygen supply and bronchodilators and pulse oximetry. So here 21st question. Which of the following is used for data mining? 1. DME orders. 2. Prescription claims. 3. Medical claims. So here our answer is D. For data mining, we use all orders like DME orders, prescription claims and medical claims. Question number 22. Post-op diagnosis is end-stage renal disease. The patient has underwent liver transplant in the past. He already has an AV fistula in the left arm. The fistula was not sufficient for dialysis, so they are exploring to make sufficient. What is the code we can use? Here in this question also is nothing critical. So first our answer is C. First we need to code ESRD code like N18.6. Next Z94.4 is for dialysis status, and Z99.2 is for liver transplant. So here we got 3 codes, so answer is C. Next question, 23rd. Medical record submitted for RADV can have conflicting document. So basically they are asking you, so if you have medical like conflicting document for RADV, can you use it or not? Here our answer is no. So document must be complete, concise, consistent and legible so that we can code. We can use that document for RADV. So here our answer is A. Question number 24. In physician or outpatient record, which of the following qualifiers can be used to report a definitive diagnosis? These all are like conditions which are uncertain conditions, like A probable, B possible, C rule out, D none of the above. Here our answer is D. Basically in outpatient setting, we will not code uncertain diagnosis as suspected conditions as like conditions with probable, possible or rule out. So we will not code all these conditions in the outpatient records, but we can code these conditions in the inpatient record. So when the discharge time, the diagnosis is not confirmed by the physician in inpatient setting. So outpatient setting we can't code this. So our answer is none of the above. So we can't consider to code this as confirmed diagnosis in outpatient setting. Here our question also related to the outpatient setting. So we can't code. We can't code any one. Probable, possible, rule out. So here our answer is D. 25th question. Is super bill an acceptable source to report diagnosis for risk adjustment? Here answer is C. No. As per CMS, super bill encounter form is not considered as face-to-face visit. So as a risk adjustment coder, we need to check whether patient and the physician has face-to-face encounter or not. It is a more important principle of risk adjustment coding. So in this coding, just the encounter is face-to-face needs to have. So here our answer is C. So as per super bill, encounter form is not considered face-to-face visit. So guys, I hope you understand these rationales or everything. If you have any concerns or comments, please mention in the comment section. In near future, we are going to publish few more sessions related to risk adjustment coding. So please subscribe, like and comment and share our channel to other people who are in need of certified risk adjustment coder interview questions and answers. Thank you guys. Happy coding.